If you want to come and grab a seat, the table, or there's plenty of space. If we haven't met before, my name's Jo Armstrong and I'm the CEO of Cystic Fibrosis Australia. It's wonderful to see you all here in the beautiful river city of Brisbane. I just wanted to take a few moments to acknowledge the traditional custodians of the land that we're meeting on today, the Turrbal people, and pay my respects to their elders past and present. It's great to be here together. The last conference we had was in 2019 in Perth. I'm a little bit curious to see if anyone in the room attended the Perth conference. Quite a few of you. Okay, well, I didn't, wasn't around then, but yeah, it's great to be back after 5 years and a few challenges through COVID. I've just got a couple of housekeeping items to take care of. So if you need anything in the next day, today, please see Katie and Mika, who are wearing the beautiful blue jackets at the back from the Icebergs events team, and they'll be able to help you with any questions that you have. Our plenary sessions and concurrent stream A will be held in here for today, and the stream B will be in room P11, which is just next door, so don't have to go too far. Make sure you've downloaded the conference app. Details were sent to you about this last week from the Icebergs events team, and all the instructions to do that are in the email. The sessions will be recorded, so that will be available at a later date through the CFA website, and we'll send a correspondence about that as well. So if you're not sure which stream to go to, don't worry, you'll be able to access the other one later on. If you have got pre-arranged dietary requirements, make yourself known to the convention centre staff so they can look after you. If there's an emergency, such as a fire, the staff will direct us on where to go. Of course, just a friendly reminder to remain safe around infection control. We've got plenty of space, we've got hand sanitizer, we've got masks, so just a reminder for that. We have an excellent programme ahead of us today, and this was only possible because of our committee who came together to pull the programme together for you. Would our committee members just mind standing up so we can appreciate you for your time and effort? It's been over a year of planning for today, so yeah, thank you to everyone in the committee for volunteering your time. Today wouldn't be possible without our sponsors, so I'd like to acknowledge Trusted Care, who are sponsoring our morning tea that we'll be having shortly, and also Mediplast, who will be sponsoring our lunch and also the recording as well. So thank you to our sponsors for supporting us. Okay, I'd like to introduce the President of Cystic Fibrosis Australia, Scott Lancaster, to share a few words. Let's welcome Scott.
Sorry, a little bit of a height differential between Jo and I. Yeah, look, good morning everyone and welcome. Yeah, I am Scott Lancaster and I'm the President of CF Australia, and I'm also the President of Cystic Fibrosis Tasmania as well, so greetings from Hobart. If you'd told me when our first child was born, gosh, and diagnosed with cystic fibrosis that 25 years later I'd be standing in an auditorium and welcoming you to the 15th Australasian Cystic Fibrosis Conference, I probably would not have believed you. And if you told me that our daughter would still not only be alive, but also well after 25 years, I would probably have also had my doubts. Such were the expectations for people with CF at that time. Fortunately, so much has changed since then. One thing that hasn't changed in that time, though, is the commitment of CF Australia to raising the profile of CF nationally and to improving clinical practices and patient outcomes for people with CF, regardless of where they reside in Australia. As the peak body for people in Australia with cystic fibrosis, CF Australia performs a number of functions that can really only be carried out by an organisation with a truly national focus. So CF Australia is, for example, the custodian of the Australian Cystic Fibrosis Data Registry, which stores information about virtually every person with CF in Australia who is treated by a CF clinic. Data that's used by CFA and others to advocate for the health resources needed to support people with CF, including the availability of modulator therapies on the pharmaceutical benefit scheme, and data which is used to monitor the impact of those treatments and resources. CFA also works to improve the delivery of clinical care for people with CF through the peer review program and is the custodian of the official CF standards of care. And every 2 years, CFA organises the Australasian Cystic Fibrosis Conference, which over 3 days brings together the doctors, nurses and allied health professionals from around the country who provide clinical care for people with CF in every state and territory, and which brings together members of the CF community for the non-medical or lay conference in a way that unites, informs and hopefully inspires both medical and non-medical attendees alike. The medical conference that started on Friday and ended yesterday has already been a resounding success, which has only been added to by the fact that, as Joe mentioned, it's the first time since 2019 that people have been able to come together in the same physical space. And now it's your turn as part of the non-medical conference. I know that we're only at the start of the day, but I'd like to add my sincere thanks to the organising committee for the lay conference for all their hard work in putting together a range of speakers and presentations that I hope you will find as informative and inspirational as the attendees of the medical conference found that event to be. And lastly, but by no means least, I'd like to thank and congratulate the small team in the CFA office led by our CEO, Joe Armstrong, for all their hard work on the conference. This is the first conference held in Australia since Joe took on the role of CEO, and hopefully by the end of today you'll be agreeing with me that she and the organising committee have set a very high bar indeed for the next time that we come together as a CF community. So on behalf of the board of CF Australia, welcome to the conference. I hope that you leave here today with newfound knowledge, new connections and new hope. Thank you.
Just lower the microphone a little bit. Thanks, Scott. So as Scott mentioned, over the last 2 days, it has been the medical conference, and that was chaired by Professor Keith Uwe. So he's going to come and share a couple of thoughts with us and reflections on the conference. If you don't know Professor Uwe, he's the Associate Professor at University of New South Wales Medicine, Health and Paediatric Gastroenterologist at Sydney Children's Hospital. He's actually had over 145 journal articles published. He's a real rock star. And apparently, he didn't have any grey hair before starting leading our medical committee. So let's welcome Professor Keith Uwe.
Morning, everyone. It's really nice to see everyone today. I think it's an absolute pleasure to say hi to each of you to the lay conference of the 15th Australian CF conference. So we did have an exciting program that was lined up over 2 days, featuring some leaders in CF internationally and also nationally. So really, I think it's a bit strange when I woke up this morning feeling like I'm actually missing the conference, the medical part of the conference, even though it was quite a bit of labor though. So, but I'd like to thank Dr. Joe Armstrong for the opportunity bestowed to me, and so thank you for that. So I'm not going to do too much covering of what happened the last 2 days, because I think the lineup of today's and at the conference today would really do most of the justice. But I just wanted to share with you the theme of the conference for the medical conference, which is really to try to connect the multidisciplinary team together. As you know, it's essential that we, in this time of the era of CFTR modulators, to try to keep the team together and actually, if anything, strengthen the links that exist between the multidisciplinary team, not to weaken it. So the sessions were really intended to put together a collaborative, interconnected approach. And hopefully through a unified vision and purpose, we can actually translate to better care clinically and also better research. And I think one of the key things that I want to say really is the engagement of everyone here today is essential to continue to move forwards in terms of our research in Australia. So one of the key highlights from my point of view was really for the first time, and it may sound trivial, but actually absolutely essential. We wanted to, I guess, increase the stature of the conference, but also to improve the visibility of the early career and mid-career researchers that are engaged in the CF community in Australia. So all the abstracts that were accepted for the conference were for the first time published in a high-impact journal in respirology. We also provided oral presentation awards and best poster awards, again, to support our community. And for the first time, we also had people with CF and also CF community impact integrated into our medical community and our speakers and our panel. So I'd like to thank you, to those who contribute to this and who shared the experiences to the CF community from a clinical point of view. And that was actually the absolute one of the highlights, I think, from the feedback that I received from my colleagues and friends. So we had lots of amazing international plenary speakers, and the two of them will be sharing some of the insights today. We also had national speakers, and a lot of things that we covered were really relevant to today's community here, right? As in terms of how we're going to model our care of CF in the future, and what does a multidisciplinary CF clinic look like. So I think it's absolutely essential for me to acknowledge the behind-the-scenes people that made the medical conference successful. So these are all the people that was essentially my dream team putting together and making everything hopefully a great medical conference the last 2 days. And again, absolute thank you to Joe, Nikki, and Bianca for really supporting and providing this platform for us to do this conference. Enjoy your conference. So I would like to now transition and absolutely like to move on to the keynote plenaries for the lay conference. So our first speaker is Professor Susan Ahern, who is a medical administrator and academic in health services research and management at Monash University. As the head of the clinical outcomes reporting and research program, she's the Monash academic lead for 5 national clinical quality registries, including the Australian CF data registry since 2016. She has published over 80 peer-reviewed papers, 35 technical registry reports, and essentially an expert in registry. She's currently a member of a number of national committees regarding clinical quality registries, and is a co-chair of the Australian Clinical Trials Alliance Registry Special Interest Group. And her work informs national registry policy and practice, and we're delighted to have you today. Thank you, Susan.
Thank you so much, Keith. It's a pleasure and a privilege to be here today. All right, so I've been working with the Cystic Fibrosis Registry now for about, since 2016, so it's at about 8 years, and it's a wonderful registry. I'm just going to check. All right, I'd like to note in particular that the registry is funded through Cystic Fibrosis Australia, as well as the Department of Health, and Vertex Pharmaceuticals provides some funding for a quality improvement program that supports data collection at the sites. I'd also like to acknowledge a lot of people that contribute to the registry, including not only my team, but the steering committee of the registry, the consumer representatives we have, all the CF centres and all the people with cystic fibrosis who contribute their data to the registry. So the data registry, if you don't know, has been around a long time. It's had 26 years of data collection. We have a wonderful steering committee that comprises a chair of Professor Peter Walk, Professor Andre Schultz is the Deputy Chair, Joe and myself are also on the steering committee, and we have a very multidisciplinary steering committee membership now too. As well as the people I've mentioned, we have adult CF physicians, paediatric CF physicians, allied health practitioners, we have a nurse practitioner, and we have 4 consumer representatives. When I started 8 years ago with the registry, we didn't have any, so we've really come into the 21st century now. There's a little bit of change going on with that committee, but that's a membership as of the end of last year. So what does the registry collect? Hopefully many of you are familiar with the registry reports and information, but we do collect information regarding people who have been diagnosed with CF at the time of diagnosis and then annually or periodically throughout their life. We collect information about demographics, about the diagnostic criteria, people's genotype, what we call clinical measures, which are usually lung function, BMI, infections, those sort of things that happen regularly or get assessed regularly throughout the year. Service delivery, so a number of hospitalisations, a number of visits to the clinics, and what we call CF complications, and then transplantations of death have been the classic things that we've collected for a long time. But in the last 5 years, as you may have noticed, there's been quite a bit of change going on in the external environment. So we also, with the data payment program, are collecting data more frequently. So we have a really up-to-date, rich resource for data with the registry now. Obviously, the modulators, we collect really detailed information. COVID, telehealth use. As Keith alluded to, we've been collecting information about the multidisciplinary teams that are involved in the care of people with CF, and we have started to collect identified data. So what I'll be presenting today are data from the 2023 annual report, which is hot off the press. I'm hoping that you can go online I know you can go online to the CF website and have a look and check it out. In particular, I'm presenting information from our infographic, which I think there's a few around and about. You're very welcome to grab one. And they're designed specifically to note the highlights, particularly for consumer audience. All right, so the registry collects data from 23 health services across Australia, and we use this information to provide not only annual public reports, but also to provide reports back to the sites themselves for them to use to improve their health outcomes. The main report is in 3 sections. One is combined data, an overview of combined data, and then we have a paediatric section and an adult section. And I'll just go through those sections and present some highlights. So in terms of the combined data this year, the registry contains nearly 3,800 data related to nearly 3,800 people with CF, of which now 58% are adult, and that's obviously been increasing annually for many years. 68 new diagnoses, nearly 80% of those of which are diagnosed at less than 1 year, but we do still have a proportion that are diagnosed older than 18 years, that's 13%. Median age now of people with CF in the registry is 21.7. I've noticed that's been going up by about half a year, or about 6 months every year. And the largest demographic group now is people with CF who are in that 18 to 29 year age group. They comprise now 25% of people with CF. In terms of genotype, the most common genotype is a homozygous F508L at 46% and heterozygous at 44%. So there's 10% that don't have a F508L variant. And that's been pretty consistent in the registry for a while. In terms of what we again call the clinical measures, so obviously lung function is probably a number that everyone with CF is very familiar with. And again, we're just seeing, with the increase in symptomatic treatment or improvements in symptomatic treatment, obviously modulators, we're seeing huge changes in these being reported in the registry. So if you're looking at paediatric data for lung function, the median FEV1% predicted, 97% now, and that includes for children up to the age of 17 as a median. And only a few years ago, 91%. So big changes. Nutrition in the normal range now, really. Weight for length for children or infants less than 2 of the 54th centile, and for older children and adolescents of the 60th centile now. In terms of infections, we've seen coinciding with COVID, but even before then, there's started to be a big drop in the prevalence of infections. If we have something like Staph aureus, we had an infection prevalence of about 70% for 8 years ago, and now we're looking at around 40%. So obviously a big difference in terms of risk for exacerbations. And if we look at hospitalisations over time, that last graph, those big grey bars at the end show that older children, the majority of them do not have any hospitalisations. So we're looking at about 75% of older children are not having any hospitalisations during a year at the moment. And of those that do have a hospitalisation, it's usually just one for the year. When we look at adults, we're seeing the same changes appearing. You know, lung function again. If you're looking at the average or the median FEV1% predicted for any adult, it's increased from 70% to 79%. Nutrition, BMIs of 23 and 25 are very definitely in the normal range. In fact, we've got about 2/3 in the normal range, and we obviously have now of those that are not in that ideal weight range, we've got as many that are over as are under. In terms of infections, again, seeing big declines in things such as the prevalence of Pseudomonas. And again, in terms of hospitalisations, those grey bars show that, again, about 75% of all adults, both the 18 to 29 group and the 30 plus group, don't have any hospitalisations in a year. And again, if they do, it's usually one hospitalisation. And this obviously makes a huge difference to the ability with people with CF to engage in the workforce, to engage in education, all those really key activities of adulthood. And our report does show that we've actually got more people with CF now that have bachelor degrees than in the general population, according to ABS statistics. So obviously a very clever group. In terms of the CFTR modulators, we've been tracking the eligibility by looking at our genomic data, as well as the prescribing for those that are eligible. And these little pie graphs that I've got here show that there's a very high proportion now, since Trikafta was introduced particularly, that are on modulators. So if we look at the red pie there, we've got 66% of children and adolescents are on a modulator, or are eligible for and are on a modulator. The grey 26 area there is those that are not eligible, so we know that quite a few are not eligible, although with the recent inclusion of 2-year-old for Trikafta, we will see that as part of the pie really decrease. And only 8% of children are eligible but not prescribed a modulator, and there may be various reasons for that, including intolerance, side effects, etc. And certainly for adults, we've got 87% prescribed a modulator, 6% are eligible for and prescribed a modulator. We've got 6% not eligible, and again, only a small number, 7%, eligible but not prescribed a modulator. And the bar graph on the left shows the same sort of information, with the dark green showing the proportion of those, I think this is a paediatric graph, who are eligible and prescribed. The light green showing those that are eligible but not that are not eligible, and the little grey bands showing that those that are eligible but not prescribed. So what we're trying to do is feed this information back to individual sites. So each bar is an individual site, just so that they can have a look and see why their proportion of eligible but not prescribed may differ to others, as part of a sort of ongoing quality improvement process. And long-term outcome data is obviously continues to be really important. We're now really focusing on collecting pregnancy information. I think that's a really important signal of hope and belief in the future, when people with CF are able to and are willing and interested in wanting to be pregnant. So we've had 88 pregnancies recorded in the CF this year. It was 71, I think, the previous year, and just 4 years ago it was half that at 40. We've seen a huge jump in the number of pregnancies, which is absolutely wonderful. Lung transplants in the opposite direction. We have 9 this year. It was 15 in 2020, and I think a few years before that it was about 30. We had for many years about 30 to 40 lung transplants a year in Australia. and the survival. So now our estimated survival for people born with CF in the last few years, around 2018 to 2022, is around 61 years of age, and that's similar to the data that's reported in the US, and for patients without transplants, it's even higher. The Cystic Fibrosis Registry is also, data is also available for people who'd like to use it for research, so we had about anywhere between about 6 to 10 requests for data every year. And I'd also like to just mention one of the things that we're trying to do is to work with sites and people with CF to collect identified data. This will allow us to use the data that we've got, which is fantastic data, in more ways, including linking with things like the newborn screening program to make sure that we're capturing everyone with CF from the registry. Things like link with prescribing data so we can understand really what sort of, whether people are really continuing to use their medications or if variation in medication use is resulting in different outcomes. So we're working with individual sites to allow patients to consent to have their identified data used in the registry. And most people, 85% of those who approach, do agree. We're a big provider of clinical registries, the biggest in Australia, actually one of the biggest in the world. We have really incredibly sophisticated data management processes at Monash, and we don't release identified data, patient-identified data to anyone. We only release aggregated or de-identified data. So on that note, I'd just like to thank you very much for inviting me. I'm happy to answer any questions during the Q&A session. Thank you very much. That's...
Morning, everyone. Can you hear? Good morning, everyone. I'm Lisa Bayackley, CEO of Cystic Fibrosis WA. Good start there. I'd just like to say thanks to Susanna, and what we're going to be doing with this morning's session is just a quick Q&A with each speaker after their presentation. Before we lead into that, though, I did want to let you know that you can find out lots more information about the data registry by looking at the digital copy, which you can access through CFA's website. So please go and have a look at that. I have seen already, Susanna, sort of lots of nods and expressions around the room, so I'm sure there's some questions. Who would like to start with a question for Susanna? Over here?
Look, I guess it's quite difficult without getting too technical, but what I can say is that Monash University has the ISO accreditation means that we're accredited nationally with the sort of highest levels of data security. We have introduced multi-factor authentication, like when you go on your bank app or anything like that. So anyone who has access to the registry has to put in a password and then use their phone or something like that. So again, we're doing all those sort of mechanisms, but we just have a whole lot of systems in place, technical systems in place too, to regularly monitor traffic, access to traffic that goes to our servers or risks or threats to our servers. It's a very complex world, but we have a very sophisticated system, and I think it's really good now that we've moved from, you know, one individual working with CF data, you know, at their home on their home computer a few years ago before it got to Monash, and now it's got a really big, sophisticated organisation to manage that.
There's a question down the back there. Yes.
Thank you for the lovely talk. It was very exciting to see the changes in pregnancy amongst young women with CF. Are you able to capture parenthood among young men with CF or any age men, I suppose, through the registry?
Look, I think that's a really good question. And one of the big themes we've had with the conference was about changing goals and changing outcomes that we need to measure. So what I've been reporting is showing big changes in all the traditional outcomes, you know, the transplants, the survival, that sort of stuff. But what we really need to understand is the goal, I think the life goals for people with CF. And yes, pregnancy is the start of that, but there's much more we should be doing, including male parenthood, I agree. So I'm really looking forward to one of the things we're doing in an afternoon workshop is to really think about the data we need to collect going forward, how that better reflects what's important to people with CF. Because if only 9 people are having transplants a year, but you know lots more people want to be parents, we need to think about what we collect in the future. So thank you.
We've got time for one final question. Yep. I might just quickly repeat that, Susanna, because possibly not everyone heard. So, no, that's fine. So the question was, the people with CF have the benefit of a multidisciplinary team. Is any data being captured about psychosocial and other services accessed through that team? Hopefully I've paraphrased okay.
Yes, look, we have been collecting the proportion of people with CF that access multidisciplinary services, including physiotherapy, dietitian, which are the most traditional ones, but also now social work and the proportion that have mental health screening, which is not high. So if you look at the report, you'll see that, again, we're still in the traditional model of care, and we need to move across more to the new model of care that's required. But we have started to collect that information, and so if you have a look at the annual report, you'll see some of that. Okay, thank you.
All right, thank you so much, Susanna. It's really insightful to hear that. So I'm very lucky now to introduce one of our international guest speakers, Elizabeth Tullis, and she's going to talk about CF in the post-modulator era. I am going to keep my introductions to these individuals very short and sweet because what they have to say is going to take as much of your time as possible. Elizabeth has joined us from Toronto, and we're very fortunate to hear insights from Canada and her 30 years of CF care. She leads our adult CF clinic with over 600 adults. She's a professor of medicine, a research scientist, and she's actually trained dozens of CF specialist clinicians around the world. Welcome, Elizabeth.
Thank you for the introduction. One thing that wasn't mentioned is I actually started my CF training in Australia, so I have a great fondness for this country. I did my respirology training in Toronto, and then came to the Alfred Hospital in Melbourne to learn how to be a CF fellow, because at the time, Sick Kids, the Children's Hospital in Toronto, looked after everybody with CF. And that would include, you know, admitting 35-year-olds, which was a little bit crazy when you think about it. But in Australia, there were already adult centers set up. So I came to sort of a well-functioning large adult center and learned the skills that I needed to go back home and start the clinic in Toronto. So thank you to all the Australians that have helped me in my pathway. So today what I'm going to talk about is related to kind of what the world looks like now for people with CF. And we heard Susanna's talk was a really nice introduction because we heard some of the statistics from the Australian population of people with CF. These are my disclosures. So I think that it's been a really interesting time, certainly since the last in-person CF conference, because we've had big changes in the world. We had a global pandemic, and in the CF community, we have had the advent of CFTR modulator therapy getting to a much greater percentage of people with CF. And it's interesting because the world really came together and collaborated in COVID because we had to find a vaccine, and so researchers worked together, and the science was advanced so rapidly to bring all these treatments or vaccines to people. And it's interesting that in this time, the CF community also worked together internationally, and that the registries that exist in the different countries were working together to make sure that how we measure things is the same, so you can do comparisons. And it's by doing comparisons that you can identify places that are doing things really well, and then you can look and say, well, what are they doing there that we could perhaps start doing to improve our outcomes? And so, for example, the CF communities, including Australia, work together to look at questions such as, how does COVID affect people with cystic fibrosis? And there was a number of papers that were published looking at what happens when people with CF get COVID. And that was really reassuring because the results were sort of better than we had initially anticipated. So this coming together and working together to solve problems is something that has been accelerated in the last few years. And some of the technology used to get a vaccine for COVID is actually helping. The technology is the similar technology that will be used for treatment of people with CF who are not eligible for modulators. So we're all kind of benefiting from this global collaboration. One of the publications that came out recently was in fact looking at the survival of people with CF in Australia, New Zealand, Canada, and France, showing very similar survival, although France was a little bit ahead of the other three, which is Australia, Canada, and New Zealand. And again, we can now learn what are they doing differently in France that leads to a small but significant improvement in survival. This has also been, the last few years have been an exciting time for advances in CFTR modulators, and this slide is from the Australian Data Registry, last year's report, and it's looking at the different modulators and the uptick in use, and the dark blue line is the triple combination of elixacaftor, tezacaftor, and ivacaftor, which I'll call ETI, but you know as Trikafta. And you can see that number has steadily increased, and now in the new report, and I saw the data that was presented during this meeting, that number's gone up even more. So more and more people have started on Trikafta therapy. And it seems now like it's almost, like this is the new normal, but it really hasn't been very long that this medication has been present. So we're still learning about not only what are the short-term improvements, but what the long-term might look like. And so what I'm going to talk about now is a little bit about the current time, and then later in the day, at the end of the day, Dr. Rosenfeld and myself will be looking to the future and what the CF community is anticipating will happen going forward with modulator therapy. You saw already today that the population of adults with CF is growing, and that was even before the start of modulators. On the left is the Australian data, on the right is the Canadian registry data. Basically looks the same. And we're seeing this difference in healthcare encounters. So what's happening is there's more adults with CF, so the adult clinics are getting larger, more patients. And there's slightly more clinic visits. But what happened with COVID is that there was a switch to going from every visit or almost every visit in person to going to more virtual visits. And you can see on this diagram here that we have the virtual visits and the in-person visits, and when COVID restrictions disappeared, the virtual visits stayed. And there's lots of advantages of virtual visits for people with CF because it means that they may have a very short time virtually with their team as opposed to sometimes an entire day going to the clinic. And so there have been these changes that have happened that I think have been a positive change. Okay. Now, the other thing that's happened, and this is American data, is showing the real-world experience about fewer exacerbations. So the studies of ETI showed that there was a 63% reduction in the number of chest infections that happened in people with CF on the medication. And that has been borne out in real-world experience. And so this is data from the American registry looking at all ages, children, young adults, older adults, all showing this drop in the number of hospitalizations for chest infections. And so that's a good thing, obviously, but it's also a change. And so when hospital administrators see a drop in admissions, they're sort of like, oh, well, you don't need a big team anymore because you don't have as many admissions. And they're not perhaps appreciating the kind of fact that the population is getting bigger, or there's different types of problems. And so it's very important for the CF team to look at this data and help interpret it for hospital administrators, because their interpretations might not be as accurate as the frontline people. And this is showing Australian data that there are not only fewer chest infections, and that translates to fewer hospitalizations. And so when we look at the real world experience with ETI, and we are sort of saying when a clinical trials showed us what happened to lung function, what happened to chest infections, the short-term data, now in the United States, they have had ETI for long enough that they can actually look at the overall impact. And you saw some of that Susanna showed in Australia, the number of transplants has dropped off. So the clinical trial data has been borne out by the real world data. And in fact, in some ways, the real world data shows a bigger impact. There's almost an 80% lower rate of chest infections and almost 75% reduced hospitalizations. The rate of death is down by 72%, and lung transplants in CF are almost none on this therapy. Now, we've only, even in the United States, who had access to ETI since 2019, the fall of 2019, that's still only less than 5 years. And so we don't have the long-term data, but certainly the medium-term data is showing this very positive trend. You can see that this is a global thing. Here's the European registry, the Canadian registry, the US registry, and the Australian registry, all showing this big drop in lung transplants. And this is actually important too for the CF team to realize that transplant teams, it would be important that they don't forget how to look after people with CF post-transplant, because people with CF have CF issues post-transplant that the transplant teams need to be aware of. So it's really important that although we're having fewer people with CF require a transplant, that we need to make sure that our transplant teams are aware of the complications, and the CF teams need to be very involved in post-transplant care to make sure that we're not missing the management of the diabetes or DIOS or things like that after transplant. The lung function is improving. This is American registry data showing on the left in 1992 all the way to 2022, and looking at lung function divided into categories, with the dark red color being people with lung function below 40% predicted, and the green showing people with FEV1 above 90% predicted. And you can see over time that green bar has increased, and the red bar in the 2022 data is so tiny you can barely see it. And this is for 18-year-olds. So this is at the time of transition. you can see that most people have good lung function. And we're seeing that overall with trends too. So I just want to leave you with a few couple thoughts. And one of them is something we should have guessed, but didn't really. And that is, what do people do when they feel well with better hope for the future? And the answer is they start families. And so we can track the pregnancy data, and you've seen that. But the registries so far have not been collecting parenthood data, and that's something that I think all the registries are recognizing. We're not really capturing the full scope of things. But single center publications are showing that the trend is that men with CF are becoming fathers too. It's not just pregnancies in women with CF. And the future and the current status is very good, is in fact sort of, for someone who's been doing this for a while, is almost unimaginably good. But there still are challenges for people living with CF. And there's challenges even when you're on a modulator. And some of them are because this is such a fast change that people have an idea of themselves and their future, and that's been shifted. And it's been shifted for the better, but change is difficult to sometimes process, and it's happened quickly. There's been a change in life expectations. There's been a change in people's thoughts about their future in terms of career. A lot of my patients have said to me, you know, I might have chosen something I liked better as a job, but I figured it didn't matter because I wasn't going to be working for 40 years, and now it looks like I'm going to be. Or people said, I have a great life insurance policy, so my family will be fine. And that's really how I was thinking of the future. How would my family be cared for if I wasn't around? But I don't have any retirement savings. And so there's been these challenges, these new challenges that are coming. And in spite of having good therapy in the form of modulators, we're still doing all the other stuff too. So there's still this burden of care that we need to address. And finally, there's the challenges that come if you're not in that group of 90% of people who are eligible for a modulator, where you feel a bit left out and not so certain about your future, and the kind of complexities of what the next therapy will look like. We're still relatively early in that process. And so in Australia, there's about 7.2% of people with CF who are not eligible for a modulator, and it's very important for all of us in health, CF healthcare not to forget about the challenges of that group. And finally, to say there's lots of research questions, and one of the things that has changed over the last 10 years is that researchers are asking people with the illness, what are the most important research questions? And this is happening around the world. This is the UK, where they have asked people with CF, what are the top 10 research questions? And of course, number one is what options are available for people who don't have modulators. But I think further down, number 8, how do we simplify therapy? How do we decrease the treatment burden? So you can see there's lots of questions that still need to be answered, but the community is involved with the prioritization of them. So in conclusion, this is a time of change. It's a time of uncertainty for people with CF, sort of good uncertainty, but it's still uncertainty. It's a lot of uncertainty for CF teams as well, but it is a big time of hope. And we need to have a plan going forward about how we're going to adjust our model of care to reflect the current situation. And we need the help and the partnership of the entire CF community, including people with CF and their families, to help direct our approach. Thank you very much.
Thanks, Liz. Do you wanna, thank you for the fantastic talk. It's really exciting times. So maybe we should field one question just from a timing perspective. Any questions from the floor? There'll be. plenty of opportunities, I'm sure later as well. I guess one, there we go.
Actually, I'm surprised that telehealth had stayed so high after COVID, because in Australia, certainly during COVID, it whipped up, but then it dropped off completely, and we went back to a very hospital-based system. So I wondered what your view was. Is that because people with CF used the opportunity to self-determine what was safe for them?
Yeah, I think it's a lot of factors. I think that people with CF are more informed consumers of healthcare, and so they could see the advantages of these complex visits when they're virtual can be much more efficient. And the team, they can talk to all their team, et cetera. And so I think that for lots of reasons, convenience, infection control, all of these factors that are important with people with CF, that virtual visits, I think, are here to stay. There has been, in different countries and in different centers, there's been sort of a readjustment. Some places are having more virtual visits than other centers or other countries. But I think that we have to recognize that there's a big difference in the burden of care coming to a clinic, and we have to adjust our model of care to reflect that.
Thank you, Liz. So it's with great pleasure to introduce my next speaker, Dr. Margaret Rosenfeld. So she's a pediatric pulmonologist, so she's sharing her insights from a pediatric perspective. So Margaret's Professor and Associate Vice Chair for Clinical Research in the Department of Pediatrics and Adjunct Professor in the Department of Pediatrics at University of Washington. And she's at the Seattle Children's Research Institute. Thank you, Margaret.
Thank you so much. Well, it's really an honor and a pleasure to be here today, and I'd like to thank the organizing committee so much for inviting me to speak. And just like Dr. Tullis, I have a great love of Australia. I came with my family here to Brisbane 13 years ago to do a sabbatical with Dr. Claire Wainwright and Dr. Peter Sly, and my kids all went to Brisbane State High School for a semester and didn't like the uniforms at all, but really loved the rest of the experience. So thank you so much. I was given the topic of progress from the USA from a pediatric perspective, which is rather a daunting topic. So I thought that I would just focus on 3 select areas. The first one is what we've learned about how ETI, or Kaftrio, improves lung health in children with CF. The second is some work that we're doing to understand how to manage pulmonary exacerbations in children with CF. And the third one is ensuring that no one is left behind in terms of curative or life-changing therapies and how to help the last 8 or 10%. Here are my disclosures. So I thought I would start off with a case of one of my patients, Liam. So he started on elexacaftor, tezacaftor, ivacaftor, that's way too long to say, so I'll just call it ETI, at the age of 15. And before that, he'd been on one of the less helpful modulators, tezacaftor, ivacaftor. So before he started ETI, his lung function was about 78% predicted, and he was spending a lot of time in the hospital, 2 to 3 hospitalizations per year for exacerbations, which was making him miss a lot of school, but he was still a straight-A student. He had a daily wet cough, and he really didn't exercise a lot because it made him short of breath. His nutritional status was pretty good, but he was on insulin for diabetes. After he started Trikafta, his FEV1 zoomed up to 105% predicted. He's had no further hospitalizations whatsoever, so the only school he misses is to come see me for doctor's appointments and our multidisciplinary team. His daily cough is all gone. He's very much still a couch potato. He loves to sit around and play video games. His body mass index has improved now to the 75th percentile. He's still on insulin. His CF-related diabetes really hasn't changed much. And I'm proud to say he's starting university. I just went to his high school graduation, and he's studying video game design, not a surprise at all. And here's a picture of me and him at his last visit before he transitioned to adult care. And you can see he's a very healthy guy overall. So, of course, the game changer here is ETI. And here's a slide from our registry in the United States showing the ever-growing number of people who are on ETI in the United States. So it's currently about 80% of people and continuing to grow. We've had ETI for 2 to 5-year-olds now since 2022. And so we've had a little bit more time to have people be eligible at the younger ages. So the first area that I'm going to focus on is what we've learned about how health changes after initiating ETI. I'm going to be focusing mostly on lung health. I'll just skip ahead and say we know there's a great effect on weight and nutritional status, but the GI symptoms of cystic fibrosis don't appear to change as much on ETI. There's some improvement in terms of CF-related diabetes, but not super dramatic. And there's probably not effect on liver disease. So of course, as we start these at younger ages, we're hoping to prevent some of these complications. But for right now, I'm going to focus on lung health. So we'll look at lung function, chronic symptoms, and treatment burden. And I'm going to focus on 2 real-world clinical effectiveness studies, which means instead of the rigidness of clinical trials, looking at how these really work in the real world. The first one is the PROMISE study from the United States, which I've been fortunate enough to help lead. And the second is the RECOVER study from the UK and Ireland. I know I was supposed to stick to the United States, but that didn't really seem very fair. So I'll cover some data from both of these studies. The PROMISE study in the United States has enrolled a large number of people over the age of 12, as well as about 125, 6 to 12, and been looking at different parameters to evaluate lung health. And in the RECOVER study in Ireland and UK, it's only enrolled people over 12 and has been looking at slightly different, though a lot of overlapping parameters in terms of lung health. So what have we learned about in terms of lung function? The FEV1, which is the measure I know you're all familiar with from clinic. And you can see from the PROMISE study that there's been a huge improvement, which you're not surprised to see, and I'm sure many of you have experienced this yourselves and your families. And we've seen similarly huge improvement in FEV1 in the RECOVER study. And this is similar to what Dr. Tullis presented from the registry, but this is focusing specifically on people who enrolled in these 2 studies as they were beginning ETI, and then we followed them over a number of years afterwards. So really substantial improvements in FEV1, and even among those with a normal baseline FEV1. And I would also say even among those with advanced lung disease as well. And if we focus in on the 6 to 12-year-olds, we also see a big improvement. And if you look on the right, you can see that everyone doesn't improve. So the red line is the average improvement, and most people are above that, but there are some people who haven't improved as much. So we have to be cognizant that ETI doesn't help everyone equally. So if we look at symptoms and respiratory quality of life, there's a standardized questionnaire that people answer, and you can see a marked improvement or increase in that score in both the PROMISE and the RECOVER studies. And in fact, the score normalized to the completely normal level in about a third of people in the PROMISE study at 6 months of age. They just had a totally normal score in terms of the general population. So that's pretty remarkable improvement in quality of life. And then I'm sure you're all aware of this as well because you're living with it, but people with cystic fibrosis are really using a lot less of the chronic, burdensome, daily inhaled therapies, and I'll be talking about that a little bit more this afternoon. So you can see the numbers of people using various different treatments has really gone down as they've stayed on ETI over a longer period of time. And that's really wonderful news. On the other hand, we don't have a lot of an evidence base to understand how safe that is for all people, and I'll be talking about that a little bit more this afternoon. That's also true in the younger children, and there's a big question about whether these therapies even need to be started in our very youngest children once they're stably on ETI. So for the second part of my talk, I wanted to focus specifically on developing an evidence base for managing pulmonary exacerbations or chest infections in children with cystic fibrosis. And I'm presenting just a little bit of our program on behalf of my other colleagues on our team, Dr. D.B. Sanders from the University of Indiana in particular. So we are all aware that pulmonary exacerbation management is a real priority for the CF community. And people in the CF community are very interested in simplifying treatment, in making sure that we provide good antimicrobial stewardship when we're using antibiotics, and that we're minimizing adverse effects of antibiotics in individuals with CF who see so much in the way of antibiotic exposure over a lifetime. And I would just have to say that this partnership with the CF community is just incredibly central for doing research that really addresses the needs of the community, and for making sure that our studies are designed with input from the community, and really designed with deep engagement from the CF community. And that's been one of the most rewarding parts of my career, is to make sure that that happens. So in children, this, what we call a pulmonary exacerbation or a chest infection, where cough increases and there may be other respiratory symptoms and feeling unwell, and typically treated with antibiotics, are very common. On average, children have about 2 or 3 of these a year. And while IV-treated exacerbations have gone down because of COVID first, and then also because of VTI, the outpatient exacerbations haven't changed all that much. So this is an area that we really need to understand. And almost all of these are managed at home in the outpatient setting, and often just diagnosed and treated by phone without ever an in-person encounter. So we really need some evidence about how to best treat these, and do they all need antibiotics, or will some of them just get better on their own? So we need to balance the possible adverse effects of treating all of these with antibiotics in terms of increasing antimicrobial resistance and rash, diarrhea, allergies, other things that happen when you see so many antibiotics, against the possibility that they improve outcomes, but we really don't know that to be the case. So this balance is probably different now that so many people are on ETI, so this is an area that we really need to study. So we've developed what we call our Stop PEDS studies with deep community engagement. We conducted a lot of focus groups to inform the study design features. Parents have participated throughout all aspects of study design, and they've helped us produce all of the study materials, and reviewed all of them and given really important input. So first I'm going to present results of a pilot study that we've now completed, and then move on into our planned study, which will answer some important effectiveness questions, and which will begin this fall. So we started with a pilot study, which was a randomized study where people were randomly assigned, and I'll point that out in just a minute, to 2 ways of treating outpatient exacerbations. And we enrolled 120 children, 6 to 18 years of age, when they were well, and then followed them through 1 chest infection. So participants were randomized when they developed a new cough to one of 2 different treatment choices. The first one was immediate oral antibiotics, where they were treated right away with a new cough with 14 days of oral antibiotics, as well as increasing chest physio or airway clearance. And the other choice was what we called tailored therapy, which is more of a watchful waiting approach. So airway clearance was increased right away, but antibiotics were only started if their cough got worse or failed to improve. So we enrolled 120 participants, and you can see on the right side about 63 of them actually had a chest infection. 30 of them were randomized to immediate antibiotics, 33 to tailored therapy. Of those who were randomized to immediate antibiotics, they essentially all, 29 of the 30, did receive 14 days of oral antibiotics. But those who were randomized to the tailored therapy, of those 33, only 10 end up needing oral antibiotics. The rest of them were able to get better on their own without oral antibiotics. So we avoided antibiotics in 70% of those patients. So that was much more avoidance of antibiotics than we had anticipated. But of course, this study was just a pilot feasibility study. We didn't answer the question of whether that was safe and what the long-term effects were. So we did learn that this study design was feasible and that managing a single mild exacerbation in children of school age could avoid oral antibiotics in about 70% of those who tried this tailored therapy or watchful waiting approach. So that led us to think, yes, we can do a trial where we're actually looking at the outcomes of these two approaches and trying to understand if one is better than the other, if the tailored therapy approach is safe over the long haul. So now we're embarking on a randomized controlled trial in a much larger number of patients over a whole year to understand about the safety and effectiveness of this tailored therapy approach. And we're going to be beginning this study this fall. Actually, that's in North America. I guess it would be in the spring here, but in September or October of this year at 33 sites throughout USA and Canada. And we're going to have 3 cohorts. The main cohort is children ages 6 to 18 who are on ETI, and we'll roll about 310 in that cohort and follow them for a year. And then 2 smaller cohorts, 3 to 5-year-old children and those who are not eligible for ETI. And there'll be about 60 in each of those cohorts. And we'll only study them through their first exacerbation, and then they'll be done with the study. And so this is complex, but I can just walk you through it. Basically, people enroll when they're well, and every week they get a text saying, are you having new or increased cough? And if they say no, nothing happens. If they say yes, one of our research coordinators calls them to see if they're really too sick to be randomized or if they can be randomized to one of the 2 arms. And then if they're randomized, they answer a number of questionnaires on their phones each day and come in for one visit at the end of the exacerbation period. Then those in the pilot cohorts, the smaller cohorts are done. Those in the main cohort do that same thing for any subsequent exacerbation over a 1-year period. And we're going to be looking at changes in lung function over time, symptoms, and a whole bunch of other parameters as well. So stay tuned there. And then I wanted to end by talking about initiatives that are being undertaken to make sure that no one is left behind and that the last 10% have access to life-changing therapies as well. So in the United States, the Cystic Fibrosis Foundation has undertaken a huge initiative called Path to a Cure, and there are many other similar initiatives around the world. And the idea here is to develop life-changing therapies for individuals who are not eligible to or can't tolerate ETI. And these include different kinds of CFTR modulators, different kinds of therapies for nonsense mutations, messenger RNA therapies, which have been accelerated because of the COVID vaccine and can be used for any kind of mutations, gene editing, and short nucleotide or ovoid therapies. And you'll hear more about these from Claire Wainwright a little bit later today. So those obviously are going to be very large undertakings, and I think we need to be all realistic that they won't come quickly, but I have every confidence that they really will come. And that's one of the most exciting and important things looking towards the future. I just wanted to end with a study that is just being started in the United States that's called the REACH study, or Research Expansion to Advance CF Therapeutics for people with CF without modulators. And this is a way to allow people who haven't been able to participate in a lot of the research to participate in research, to get baseline data on people who are not eligible for ETI so that we can design these upcoming studies with all the necessary data. So what we're doing is collecting baseline data on people who are have not historically been involved in clinical research. Then again, these will be used to develop these trials and also to be controls in future trials. And there's just been huge work to engage people with CF in the United States who haven't traditionally been involved in research, often from minoritized backgrounds. And we'll be talking a little bit more about that this afternoon. So it's really a critical undertaking, and I have to applaud the principal investigators of this study and the CF Foundation for really trying to make sure that we have the necessary data to conduct the clinical trials in these gene therapy and other studies for people who are not ETI eligible. So in conclusion, in real-world studies, Kaftrio or ETI is associated with marked improvements in lung function and respiratory symptoms or quality of life. We're developing an evidence base for treating pulmonary exacerbations in children, but the picture isn't uniformly rosy. And many people who started ETI must adjust the dose or discontinue it due to side effects, and 10% of people with CF are not modulator eligible. And as we'll talk more about this afternoon, around the globe, the majority of people with CF have no access. So I want to give kind of a balanced picture of the current situation. I also want to end by just saying that engaging with the CF community to make sure that we have a research and advocacy agenda that meets the needs of the CF community all around the world is just of critical importance. And I thank all of you for all the work that you've done and for being here today. And we can join together as a community to make sure that no one is left behind in terms of CF. Thank you.
Those that are joining this session